That's perfect. Thank you, Kevin.
You're welcome.
Okay. So hopefully everybody's can view the screen. You should be seeing a slide right now. I'll go through some general housekeeping in just a minute. Dan, you want to go ahead and kick off our meeting today?
I do want to go ahead on behalf of the Foundation for Healthy Communities and the New Hampshire Department of Health and Human Services, Bureau of Drug and Alcohol Services. It's my pleasure to welcome you to the first MAT community practice meeting that we have held in just about 6 months. We have been delighted over the past couple of months to work with our new partner, appropriately named Growth Partners. And today we have handed them the challenge of one of the most logistically complex webinars they have ever been a part of or seen. But we are glad to have their assistance, and Mary Ellen Shannon will be guiding us through this process, and we are grateful for that. This has been on the front burner for a long time, and I want to thank Peter Ames, the Executive Director of the Foundation for Healthy Communities, and Nick Carano, who is the Director of Financial Policy and Reimbursement of the New Hampshire Hospital Association. It's been planned for a long time. Nick stepped away from his work at the Hospital Association last spring to serve for several months on the front lines of the COVID-19 pandemic. And we are glad to have Nick back and safe. And he has lined up an excellent group of speakers to address your questions and to make presentations. I also want to acknowledge Lindy Keller, who has been the energizing partner from the Department of Health and Human Services. And Lindy has guided our contracts to a new fiscal year and has been deeply involved with the onboarding of our new TA partner. We will be planning for 3 more community practice sessions this fiscal year, scheduled for January, March, and May, and dates will be forthcoming. We are currently assembling a planning group and plan to be in contact with you about some of the background work that Growth Partners has done. And as well, that planning group will have access to that. And it looks like it's going to be a very energizing and interesting few months in this community practice. Mary Ellen, did I cover everything I needed to cover? And can I turn it back to you?
Absolutely. Thanks, Dan. Good afternoon, everybody. My name is Mary Ellen Shannon, like Dan mentioned. I'm the director of the New Hampshire's Technical Assistance Center. We're the new TA provider, like Dan mentioned, and we're very excited to partner with the foundation and for this community practice meeting, as well as for all technical assistance services and all communities of practice. Some of you may have participated in a community of practice member survey recently. That's a survey that we sent out to collect some feedback from folks on how the communities of practice are going. And we will be picking up and offering resources to folks and coordinating technical assistance. We've actually already begun. And we're actually probably going to be launching our website in just a few weeks. So we're very excited to be the new kid on the block and look forward to getting to know all of you. So just some general housekeeping. Hopefully all of you in this new age of Zoom and meeting virtually, I know some folks are even zoomed out by this point, but you've probably navigated the controls pretty well by now. But just in case you haven't, if you're having any difficulty hearing, that's why I've got this troubleshooting up here on the screen. This is a recorded event. So we just ask folks, when you're not speaking or if you've got some other things going on in the background, please do mute yourselves. If you keep yourselves muted, one way to come off mute when you speak is to just hit your space bar, or you can just use your controls to unmute yourself. If you do have a role in presenting, please make sure that you are comfortable unmuting yourself and finding that control now. We encourage everybody to use the chat to submit your questions. We have a total of, we have like 3 different presentations this morning on different topics related to financial issues and SUD treatment, but multiple presenters. So we actually have a robust group. presenters this morning. So please do enter your questions, comments, anything that you want to make sure that those presenters cover, or you have questions about, please put them into the chat. We'll make sure we get to those during our discussion portion. It is a 2-hour event, so please make yourselves comfortable. Take care of yourselves. We will not be breaking, but it's a lot of information that we're going to get through, and it's going to be a really rich learning, I'm sure. So that is our housekeeping for today. I'm going to go ahead and turn it over now to our presenters that are going to lead the discussion, starting out with Pam Skilton. She's a provider network specialist with New Hampshire Healthy Families. And Pam, I think you've got some others maybe that might be joining in with you. So if you want to take it from here, I'll stop sharing my screen so you can share yours.
Okay, great. Let me pull this up and sharing my screen.
Looks good on our end, Pam.
Okay, so you can see, okay. Excellent. All right, so I'm having, there we go. I've got my, all right, so I am Pam Skilton. I am the external provider services representative for New Hampshire Healthy Families. I work with the behavioral health, the substance use disorder, and the CMHC communities in supporting them. So we wanted to just provide a little bit of an overview on medication-assisted treatment, as well as a billing overview. So first, the outline that I'm going to go through, we have several slides. So we're going to talk a little bit about just a brief overview of what medication-assisted treatment is, who can provide those, some specifics on billing them, and then some resources that New Hampshire Healthy Families does provide related to medication-assisted treatment. So what is medication-assisted treatment? Basically, the definition that we use is that it's the use of medications in combination with counseling and behavioral therapies to provide a whole patient approach to the treatment of substance use disorders. And obviously, you know, it's something that we feel is a very important part of treating substance use disorder. Going on to who can provide these services. They can be provided in a variety of different settings. They can be done in primary care, behavioral health, specialty addiction treatment centers. Matt, yes?
Pam, it's Michelle. I'm sorry to interrupt, but you're still stuck on your opening slide. We're not seeing the slides as you're advancing through them.
Oh, my goodness. Okay. All right, here we go. How's that?
Wonderful.
Now we can, okay, thank you. Okay. It appeared on my side that I was, but obviously I didn't click the right button. Thank you so much. A little technologically challenged. All right. So again, so picking back up, who can provide MAT services? They can be done, the provider can be enrolled as an outpatient SUD. They can be a comprehensive SUD. CMHCs, RHCs, FQHCs, all can provide MAT services, as well as hospital or facility-based providers. There are a variety of different practitioner types that would be associated with the providers who can provide the MAT services. And these include physicians, nurse practitioners, physician assistants, clinical nurses, certified registered nurse anesthetists. I can't say that word very well. Certified nurse midwives. So all of those types of providers would be available to and able to provide MAT treatment. All right, so specifics on billing for these types of services. Typically, these are billed through the 992 series of E&M services. They would be the 201 through 205 for new patients, depending on the length of time. And then for established patients, obviously the 211 through 215 series, again, based on time. And the important thing is to differentiate these from regular E&M services would be the HF modifier that would be used. And some important things to note for the billing of these is when you're using the HF modifier, it must be in the first position. That will identify it specifically as a MAT service as opposed to just a regular E&M service. For office-based medication assisted treatment with buprenorphine, that requires the prescriber to obtain a waiver. And the New Hampshire Medical Society does provide free training to obtain those waivers to administer and prescribe that particular medication. One other comment for those facilities that are either designated as an RHC or an FQHC, when billing for MAT, the encounter cannot be billed on the same claim as the MAT service. So that would need to be put on a separate claim if you were billing that encounter as at the same time that you're billing the MAT service. So all of those situations are included in our New Hampshire Healthy Families Billing Manual, which is which you can access on our website. For MAT services, all of these same timely filing requirements are the same as for any other type of service that you would be billing. So claims must be billed within 120 calendar days of the date of service. And the reconsiderations and appeals are all the same. So those all fall again in our billing manual. So those requirements can be accessed on our website as well. Prior authorizations for MAT services. So for in-network participating providers with New Hampshire Healthy Families, there is no authorization that is required for MAT services. However, prior authorizations may be required for certain MAT medications depending upon the formulary and or dosage of those medications. So whenever there's a doubt, you can always contact the New Hampshire Healthy Families Pharmacy Department and for specific requirements as far as if you are doing a certain dosage of the medication that may require a prior authorization. So it would always be a good idea to just double check and make sure that you have all of the prior authorization requirements met. So I put together just a couple of slides on resources that we offer through New Hampshire Healthy Families. The first, we have a medical director for substance use disorders, and that is Dr. Molly Rossignol. And I put a little bio up for her. So she basically is guiding New Hampshire Healthy Families in all of our aspects of doing any kind of programming, any kind of outreach to our providers. She is available to provide consultations to providers on best practices if they are starting a medication-assisted therapy program, or if they have any questions in general. So she is a wonderful resource for us to have. And she's actually on the call today, Andrea Rankatori. She is our Director of Behavioral Health and SUD. So she too is available to answer questions from our providers on best practices and program development. So again, she is on the call today. So if you have any specific questions later on in the presentation, she can certainly help answer those. On our website, as I had mentioned earlier, our provider manual and our billing manual gives specifics as to how to bill for MAP services. We do have a Ready for My Recovery member program, and we do have information on that. We do have a whole catalog of provider training and education offerings. And that too is located right on our website, and you can register right from the website. And we have a variety of other informational guides on the website as well. So it is a wealth of information. And I also put a link there for the state New Hampshire Medicaid Substance Use Disorder Treatment and Recovery Support Services Manual. So that is the end of my presentation. So I think we were going to hold questions until the end. Am I correct?
That's correct, Pam. Thank you so much.
Okay.
That's very insightful. We've already had a question about whether or not they can get copies of the slides, and we will make sure that everybody has access to the slides following this meeting. So if you can stop sharing your screen, we'll go ahead and have Judy Demaro, Manager of Provider Network Management, AmeriHealth, Caritas, New Hampshire. If she will go ahead and look at that. She's all ready to go. Take it away, Judy.
Thank you, everyone. Thank you for having us today. So I'm from AmeriHealth, Caritas, New Hampshire. With me today, I have three other colleagues. I have Barb Muller, who is the Senior Operations Analyst. Barb, do you want to take a minute to introduce yourself and say hello?
I don't know, can you hear me?
Yep.
Okay. Hello, everybody.
Can everybody hear her okay? She was having some technical difficulties, so I have her on another cell phone joining us. Can you guys hear her?
We did hear her. Yes.
Okay, perfect.
Thank you.
Thank you. I also have Kevin Callahan with us. He is the Manager of Value-Based Contracting. Kevin, did you want to say hello?
Sure. Hi, my name is Kevin Callahan. As Judy mentioned, I'm the Manager of Value-Based Contracting and heading up our effort to put in contracts that have alternative payment methodologies here in New Hampshire.
And lastly, we have Chris Mulcahy with us, and he is the Substance Abuse Coordinator. Chris, would you like to say hello?
Yes. Hi, everyone. I think we also have Dawn here on the phone, but Dr. McNally is here.
Fantastic.
Yep.
Hello, I'm Don McNally. I'm the Medical Director for Behavioral Health and Substance Use Disorders, and I am an addiction psychiatrist by training, and I'll add what I can to Judy's presentation. So thank you, Chris.
Perfect. Thank you, guys. So we wanted to do a broad overview as we're the new MCO in the state. We wanted to just do an overview and kind of just explain who we are and what we're doing and assist any way we can as far as the billing for MAT services. We do follow the state guidance very closely and facilitate and make it as easy as possible. So our mission today was more to kind of give you an overview of who we are and what we can offer in other ways. So our mission is to help get get our members care, stay well, and build healthy communities. We are part of the managed care organization, an organization within New Hampshire, and we work for DHHS. One thing I really wanted to point out to you is that your account executives are dedicated and are specialized in each county within the state. So at the end of the slide, I do have my information. If you're wondering who your account executive is, they're actually there to support you in any of the needs that you may have, whether it's billing questions, claim questions, any type of questions that you're having about AmeriHealth Caritas, whether you need to get in touch with Dawn or Chris or any of our care managers. They're there to be that single point contact and to resolve any issues that you have with the plan. So please feel free to reach out if you're unsure who your account executive is. Please feel free to reach out to me and I can definitely connect you with who your dedicated account executive is. As far as electronic claim submission, I have this slide up. It gives you the EDI payer number. We use Change Healthcare. I also have the phone number here and the website to Change Healthcare if you're having any issues with that. You can also reach out to your dedicated account executive if you're having any concerns or questions on how to get set up with that. As far as the EFT payments, we also use Change Healthcare for that. So I have a link in the presentation and a phone number to be able to get set up for that. But if you do paper claims, we have a slide here for that as well with the billing address so that if there's any questions or concerns, you have that at your hand. I put a slide in here for the claim filing deadline. We do follow 120 days for original claims. Denied claims, if you need to do any corrections to the claim, you have 365 days from the original submission. This slide is about our behavioral health, what requires notification. So we do ask that you send us notification within 2 business days, and we do follow the ASAM levels of care. Substance abuse disorders notification is required, but we do not require prior authorization. Chris, I don't know if you wanted to jump in here and talk about any of that as we lead into the next part, which is the local care management.
Well, I think, yeah, I would just add one thing to supplement that, that although the prior auth is not a requirement, right now that notification, it really does help us in a couple different ways. I can go into that with the care management side of things, but I think the caveat being that the notifications are only required so as long as the assessments are following ASAM criteria. So that's one of the things that we want to make sure that the member, our member, your client, your patient is actually being assessed using ASAM. So that's how we get around the prior auth requirement. I think that does help us as the process goes on. We have an internal process that we use that notification for, which is probably a topic for another day, but within the care management thing. But Dawn, do you have things to add to, in terms of levels of care and things?
Yeah, so I think the important thing is, and I wish I could just say, all 3 of the MCOs are going to be very similar when it comes to certain things. So to add the caveats, much like New Hampshire Healthy Families, that no prior authorization is needed for those in network, but we do require it for out of network, and that there is no prior authorizations for medication-assisted treatments such as Suboxone, Sublocade also, and Vivitrol do not need prior authorizations for our MCO, but there are limits to dosages once you get above a certain length amount of dosage where you will need a prior authorization. So it's very similar across the 3 MCOs for what the prior authorizations are going to look like. So just wanted to make sure that we're saying it's for in-network providers.
Thank you. I appreciate that. Okay, so this is on to, we're going to let Kevin speak a little bit about our New Beginnings program. Kevin, you want to go ahead?
Sure. Thanks, Judy. Judy asked me to come here and talk a little bit about our New Beginnings program, which is a new program that we're introducing for MAT and SUD providers. The goal is to improve the health of our members, your clients, by recognizing and rewarding high quality and cost-effective care. We think the program has a very good structure that enables us to do that. Providers like it because it's really flexible and it's transparent. And in regards to provider data and the setup and the incentives, it's quite easy to work with. And I'll get into that a little bit later when I talk about our dashboard. What the providers also like is that it doesn't require any extra effort on your part because the program data is pulled from claims data. So the data is easily accessible. There's no downside risk to the program, which is great. It's upside only. And another neat thing is the program's fully customizable to the practice. So the practice works with AmeriHealth Caritas to design quality goals that could be a part of the program. And some of the examples that we've spoken with providers are follow-up with patients admitted to the hospital, follow-up with patients admitted to the ED, med management, A1Cs for patients on psych meds, potentially preventable inpatient admits, and potentially preventable ED visits. And we could do that. The program could be set up to reinforce the quality behaviors by using peer comparison, percentage increase, or gap closure. And we do in different markets all those different use those examples, or rather the quality metrics and the measurement tools in all of our different markets, and it's been really well received. You know, I think the biggest point here is that they're jointly developed and customized to the practice. And again, it's been received some really good feedback we've received. We provide dashboards, online dashboards to the providers that allows you to see your progress as we move along in the program. And you can also, one of the cool things is you can also drill down to the individual practitioner level, so you can see who's contributing to the success of the program. You also get the full support and background from your account execs. And as far as payment for the program, the incentives are paid out on a quarterly basis. So for example, if providers join on January 1st, measurement period is January, February, and March. And we have 3 months of claims run out, and then the checks are issued shortly thereafter. So again, just to kind of wrap, it's a good program. We feel it's effective, and certainly if you have any questions as part of the program or at the end of the program, let me know. Thanks, Judy.
Great, thank you, Kevin. So lastly, what we wanted to talk about was have Barb just talk for a couple minutes about billing for MAT services. Barb?
Okay, so similar to the other NCOs, we ask that you adhere to HF modifier in the primary position when billing your MAT services, and the SQHCs have to bill those separate from the encounter. Most of our guidance is published guidance that's on the state portal. We don't have any particular policies right now. We follow what the state rules are, so that's where we pull our documentation. But again, if you had any questions, you can certainly reach out to your account executive, and they should be able to assist you with any billing questions or any issues that you might be having.
Perfect. Thanks, Barb. So the last slide we have up here is my contact information. Feel free to reach out to me through email or by cell phone, and I can guide you to your account executive or help you with anything that you need. Thank you all so much.
Terrific. Thank you, Judy, and thank you to your entire team there. Wow. Again, if you've got questions, comments, anything you want to add to the discussion or want to make sure that we cover when we get to the Q&A portion or discussion portion, please go ahead and enter that into the chat. And now we've got Well Sense that's going to present some information.
Thank you so much. I will start. My name is Holly Eaton. I'm the Director of Contracting and Provider Engagement at WellSense. We have a few people joining the call today, including Diane Woodward. She's the Supervisor of Provider Engagement. Diana Richardson, who is the Director of Payment Policy and Integrity at the plan. From Beacon, we have Carrie Coy, Director of Account Partnerships. Colleen Gagney, Provider Relations Manager for the Northeast, and Kim Gordon, our SUD Coordinator. And if you all walk away with anything today, I would say the key thing you'll want to highlight and underline, providers, sorry to steal your thunder, Diana, is to include the modifier HF when you're billing for MAT services. We do see that providers can forget that. And I think that's the big takeaway from today. So with that, I'll introduce Diana, if you could share any additional details. Thanks, Diana.
Thank you, Holly. So for MAT services, like everyone else, we are also following the New Hampshire Medicaid billing guidelines and payment methodologies, which are the E&M services with 99201 through 99215, as Holly said, billed with the modifier HF. These services are paid in accordance with the New Hampshire DHHS fee schedule rates for those professional services. And any hospital payment on the facility side would be in accordance with the hospital payment methodologies. And we are using also the guidance that is on DHHS website, and that link is here. And additional information for SQHC billing is when there's both a medical visit and a MAT office visit for SQHC providers, they do have to bill those services on 2 separate claims.
Thank you, Diana. And that's it.
Okay. So that concludes our presenters, and now we want to open it up to all of you for your questions and discussion on this topic. If you can go ahead and unmute your microphone. Again, your mute button's in the bottom left corner, and you can go ahead and ask your question verbally, or if you're more comfortable, feel free to use the chat and just type your question in there. Not seeing any questions coming in. Is there any discussion points? Dan, is there any discussion points that you want to make sure are covered during this COP meeting, or Lindy?
From my end, no.
Hey,
I'll ask Lindy.
I think
can you guys hear me?
Yes, go ahead.
This is Molly Rosignol. Yeah, this is Molly Rosignol. I'm the medical director of substance use disorders at New Hampshire Healthy Families. And I will just offer up some other observations that that have come up through, my experience in on the insurance side that may be of benefit to folks who are, doing this work in your practices or otherwise. One of them that I don't think anybody touched on was, so we don't have prior authorizations for ASAM when ASAM criteria is met. So, for example, if somebody meets criteria for residential care, that's not something that goes through utilization management that then would come to a reviewer. That said, I know that in previous years with other COPs, we have done many
many, 2 or 3 conferences on ASAM criteria. I think it's always great to review it again and again and again to be sure that all 6 dimensions are addressed. In fact, ASAM has a new, it's not free, but they have a new module on their website that talks about utilization and management and ASAM criteria. Now, our state, through the MCOs, we are required to cover ASAM criteria level of care when ASAM has been applied appropriately. So that's one of the things I would just emphasize for folks to get used to in terms of really understanding the 6 dimensions, because that's really the crux of treating the whole person, of identifying individual needs for people, of doing the biopsychosocial model in addiction care, and not just kind of saying, oh, this is somebody who came in and they need residential care because they relapsed again. And that's not really necessarily the case. So that's sort of my plug for really looking at the individual and evaluating what level of care is appropriate for them. But also the fact that we don't have prior authorization for an appropriate level of care there. The second thing has to do
Molly,
with
Molly, before you go on, can I follow up with a question there?
Sure.
So if
Hey,
a person, if the ASAM criteria would indicate, for instance, residential, but the person is not yet in residential, or they're waiting for a bed, or they're not willing to go into residential at the current time, but they are engaged in MAT with their primary care provider. So how does that work out? Because we know they should still be getting the MAT even if they're not using the ASAM level of care that is indicated.
Sure. Well, what I would say to that is that, we still need to, we know that people, may not go to a residential care. They refuse that care, or determine they're not ready for that. That's not, where they are. And my opinion on that is we keep people where we meet them where they are, and we continue to treat them appropriately with evidence-based treatment. So, I would continue with MAT or with medication for opioid use disorder, and then, use motivational interviewing to talk about, what kinds of things do you think would be helpful to you? What things have been helpful in the past? Maybe it's an IOP, maybe PHP. I'm not saying that we wouldn't, I don't even see, like, our behavioral health, we don't even see these, there's no prior authorization. So it wouldn't come to me as a medical director. I guess that's my point. But recognizing that we can still talk to our patients about all 6 dimensions, and evaluating them from that perspective. And you're absolutely right. They may not want to go, and we got to meet them where they are.
Excellent comment, Molly. Go ahead.
I have one more thing, and then I'll shut up. But you said we have 2 hours, so I might talk for the next hour and 15 minutes.
Perfect.
Got to watch out. And one of the things that I have seen happen is certainly through programs, people have urine drug testing. It's an appropriate lab test to follow folks who have use disorders of any type. And I think it's important to understand, I just did a presentation for the New Hampshire Medical Society over the weekend regarding using urine drug testing, understanding what type of urine drug testing you're doing. And this is really, kind of like more of the academic component of it, but understanding why and understanding what your interpretations are. From a claims perspective or from an insurance company perspective, we do have limitations on what we cover. Our MCO covers up to what's called a G, I have to get this right. Usually I'm good with numbers, 04801. I'm sorry, 0481. And basically what it is a a urine test. It could be LCMS, it could be GCMS, confirmatory, up to 14 classes of substances, so to speak. So if there's 15 or more, like if you go with, I don't know, one of the, ABC laboratory that says, oh, we can cover 117 labs for you. And that sounds cool, but we don't really care what the olive oil level is in somebody. It's just really important to understand what you're looking for. And those things would either need a prior authorization or give me a call and tell me why you're looking for more than 15. If you say this is somebody who's been using, kratom, or it's somebody I'm really concerned about because they're in an environment where I think bath salts are really common. Absolutely, let's look for them. But in general, there might be a pushback for a prior authorization if it seems out of, just not in the norm of what's in our community and what we're treating patients for.
Thoughts,
I think
questions?
there was a question in the chat that's a billing question.
Yes. It says, I'm assuming these services are always billed on the 1500 claim form. Is that correct? That was in relationship to the presenters.
This is Pam Skilton. Yes, that would be correct. Those would be the claim form for the professional claims that most people would be using.
Okay. Thank you.
This is Diana from Wellson's. That's the same for us also. For those professional services, they will be billed on a 1500.
And this is Judy and Barb from AmeriHealth. We're the same.
Terrific.
So I'll throw out another question because all of you mentioned that you would need prior auths for certain formularies or dosages of particular medications. Is that a whole long list or is it relatively small? And if it is relatively small, could you just mention what are the formularies that are problematic or that require additional approval?
So this is Don McNally from AmeriHealth Caritas. So for any Suboxone type product or buprenorphine combination product, it would be 16 milligrams and above needs a prior authorization. And then some of the more unused or lesser used formulations like Bunavail would need prior authorization if alternatives haven't been sought. But we also have no prior authorizations on Vivitrol injections as well as Sublocade.
So this is Molly Rossnell again. Similar to Dr. McNally's statements, New Hampshire Healthy Families, I think that probably our formularies are fairly similar and some of them are directed by the state. And so, they're going to be, I am aware that we do require prior authorization for the mono product for buprenorphine. In my own personal practice, I've had patients who have been uninsured for periods of time. And so we're on the mono product because it is a lot less expensive than the combo products. Some folks are not comfortable using the mono product for reasons of diversion, et cetera. But I was quite comfortable with it. I actually did argue with our pharmacist about why we wouldn't offer that. He invited me to go before the Board of Pharmacy, and thus far I've chickened out. But I do think that it's something, if you feel that your patient is better on a mono product for whatever reason, whether naloxone for sure gives them headaches or makes them sick, because I have had patients take it in front of me and really not do well. But if there's a reason you want them on a mono product, give us a prior authorization. Send us prior authorization because that's certainly available. But similarly, of the buprenorphine / naloxone products, I believe both generic and brand name are available, tablet, Sublocade, and brand name Vivitrol.
And this is Holly from WellSense. We can send our formulary link as well and some information on this to help answer that question, if that helps, Lindy.
Thank you. Okay, I got folks started. I know there are more questions out there.
I have a question again. I told you I could talk all day. It's Molly again. If there are folks, like I'm looking at the names of folks on, I'm not seeing a whole bunch of people that I recognize as providers per se, but maybe I'm wrong. If there are providers out there, I recently received a call from, or an email from somebody in the North Country who has been getting frustrated that that they want to prescribe a higher dose than 16 milligrams, and as Don mentioned, 16 milligrams is the limit before you need a prior authorization. And I'm just wondering if there's people with experiences where they are using a lot higher dose than 16. It certainly could be a clinical discussion, or even a discussion about why or why not we might want to argue to the state to increase that level.
So Molly, I am comfortable going to the state with you about that and the mono product if you ever want to do that, just as an aside.
Thank you. I
You're
appreciate
welcome.
that.
No
Perfect.
problem.
So if we did nothing else, we got a plan. I keep showing up as Andrea Rankatori, by the way, but I'm really Molly Rosignol, and we're not sharing a phone, so that's really weird. I wish I was Andrea Rankatori.
That is funny.
So if changes were made based on you all going to the state and making a case, how would providers find out that that now no longer needed prior auth?
Typically, we send provider communication out through our provider network management teams to the practices that provide those services.
And it would be updated on the formularies?
Yes.
At each
Yep.
MCO.
I will say clinically that I have very rarely needed to prescribe more than 16 milligrams for patients, but certainly if there are cases where you find in your practice that you do, I think that those kinds of things those are important observations, and we could certainly, Dawn and I now can partner and make some changes. And I think that that's a demonstration of how things can get changed too. If you're, please feel free to contact me or Don or the WellSense equivalent, because we want to be supportive of the providers. We want to make sure that we're serving the constituents of New Hampshire and following best practices that are agreed upon for all of us in our state.
That's a great suggestion, Molly. Would you be willing to kind of share your email in the chat box?
Yep, absolutely.
Terrific. Thank you. Other questions or discussion on this topic? Dan, Lindy, it sounds like folks have gotten what they needed so far from the meeting. Is there anything else you guys would like to talk about as far as the future vision for the COP or for wrapping up of this meeting?
Sure. We are seeing, and Lindy and I, let me condense numerous discussions between Peter Ames and Lindy and myself. We are seeing some organic growth in the field of SUD treatment. And it is that kind of dynamic that is really going to be reflected in future community practice meetings. We used to segregate community practice by MAT, by project level, but it's apparent that there's been success in the integration of SUD treatment into the larger umbrella of medical treatment. So we'll be looking forward to providing things that perhaps reach out to new frontiers, cross boundaries, and provide a more integrative and holistic approach. So we're excited. How that actually plays out will be determined by our planning group, but I'm quite excited about the future of COPs moving forward. I think we have always enjoyed a very high level of quality in our presentations. I have only been a piece of that for the last 8 months, but I think going forward that we can, we'll be offering some exciting things coming up here. And I have never heard a complaint that a meeting ended too early. So I'm just okay with that if we've answered questions. And Lindy, did I capture the substance of many of our discussions, including the one we're having after this meeting?
Yeah, I think so. I would just like to say a special thank you to all the folks that represent the financial units of the hospitals for taking the time to participate in this. We know there's been a lot of confusion over the years as MAT has grown around this and as there have been changes with MCOs and whatnot. So it was really nice to get all the experts in the room and really appreciate the 3 MCOs providing contact information for their staff and I guess just reassuring folks that there are people on the other end of the phone or at the other end of the email who want to be helpful. And now you know how to reach them, or at least once you get these slides after the meeting, you'll know how to reach them. So thank you to the presenters and thank you to the financial people from the hospitals who were here today. And if you have any additional interest in future meetings, whoever you are on here, I think we can keep the chat up for just a few more minutes. If anybody wants to chat in a request for a future topic that we might address, or again, any final questions, because we can always pass them along to our presenters today, even after the fact. So.
Yes, absolutely. And I should mention too, that if you wouldn't mind, and here I'm finding my link, but if you wouldn't mind just taking one moment before you completely hang up, I'm going to put a link into the chat to evaluate this meeting. We always are looking for feedback. It really is important to us. Not only do we look at that feedback for growth partners, but we share that with BDAS and with all of the partners so that we can make sure that as we go forward, we are considering your needs. The COPs are a forum for you, driven by you to meet your needs. And so we want to make sure that you're an active part of giving your voice to that. So the link is there in the chat now. And all you have to do is click on the link. It'll take you directly to 4 questions and a Survey Monkey. And that's, we'd appreciate your participation in that.
And we do have a question from Andrea Gowan about what programs or supports are available to patients with SUD through WellSense and AmeriHealth and New Hampshire Healthy Families.
So that's a question for WellSense. Is there somebody there that wants to take that question? Hopefully they haven't hung up yet.
Hi, it's Holly Eaton. We'd be happy to share that information with you and the information that we forward after this meeting, unless Carrie Coy, you have anything that you'd like to add?
I guess just to let you know, we have care management available for any members if they need assistance in accessing services. Kim Gordon's our SUD coordinator, so she's actively working with providers to ensure a good quality of care. So I'm not really sure, I'm happy to send out some kind of resources and kind of what we offer to the group. But that's kind of where our support would come from, is more through the care management and through Kim, our SUD coordinator.
Thanks, Carrie.
How about AmeriHealth or New Hampshire Families? Any comments there that you want to provide?
So I
Hi.
would say this is, go
ahead.
This is Judy from AmeriHealth. I would say the same. We have care management. I had that in our slide deck, as well as Kevin Callahan speaking about the value-based contracting that we have offered to BA and SUD providers as well.
Hi, this is Pam Skilton from New Hampshire Healthy Families. We also have care management, and as an additional support to our members who do have substance use disorder, we have a Ready for My Recovery program, which is it's more of a reward type of program. So once they register for the program, they receive a backpack with a bunch of personal care items in it. And then when they remain in treatment for a period of time, it's like a little reward card, similar to like the My Health Pays that we also have, where a certain amount of money is placed into their account that they can use for a variety of different things. And then once they stay in treatment for longer, it continues. So that is a patient-specific program that we do offer through New Hampshire Healthy Families.
Great. And there's a cover here that all three also cover IOP.
Is that what you were looking for, Andrea Gowan, the person that asked the question? Okay.
Okay.
Yes, that was perfect. Thank you.
Okay. We'll do a final call. This is my first time attending this meeting. Having a similar meeting about the therapy H codes would be very helpful if that hasn't already happened.
Good suggestion.
Okay. All right. Well, it seems like that's a wrap. Of course, we can leave the chat up like Lindy suggested. Again, please do take the survey, and we will share the materials that were part of this meeting today. We will also be sharing a recorded copy of the meeting. We'll make that available to folks if they want to share it with anybody that couldn't attend today. Appreciate everybody's time. Have a good rest of your day.
Thank you all.
Thanks. Bye-bye.
Bye-bye.
That was really stellar. Thank you.
You're welcome, Dan.
You are gracious, skillful, and it was just great to, it's a very nice meeting. It felt very smooth. And what do you think, Lindy? How'd they do?
Well, I think it ran well. I'm a little surprised there weren't more questions. And I don't know if that's because when this topic first came up, there were loads of questions and some of them have been answered by now. I really was expecting more, particularly from the financial people. But again, maybe some of that has settled down since we started all this. And I do think the value in people having the direct connections to the providers should resolve any additional things. So it will be interesting to see what the survey evaluation survey shows up
Sure.
when you get that, to see if it's been.
Yeah.
Yeah.
One of the things, what we could do, Dan, is in future meetings, even prior to a specific topic, sometimes we could actually ask for questions ahead of time.
Yes.
Or, kind of give folks a piece of information that they kind of look at and think about prior to coming to the meeting. So I'd be happy to work with you on some of those ideas and
Excellent. Yes.
how that might, it's just one way to be able to anticipate. I always need that in order to anticipate the length of a meeting, how long do we really need to talk about this topic? And then, it just helps to know, then you've got a few prompts and a few folks kind of that can get the discussion going.
Yeah.
Well,
and sometimes I see that with planning groups.
Yeah, this was not our typical audience either.
Okay.
No, if you look through the attendees.
Because Molly, as Molly said, I mean, she knows most of the docs. She's trained almost all of the waivered docs in the state. And if she's looking at it and saying, I'm not recognizing people, there's probably not a lot of them. And when I looked through the list, obviously I saw the first list that you sent out, which since then there have been a lot more people who joined, but I wasn't recognizing a lot of names either. So yeah. I really think it was a different audience. And so it's not people who have been involved on a regular basis in this COP previously.
Yeah.
So I don't think this is typical. Well, I don't think it's typical for a lot of reasons. It was the first one that was done with Growth Partners. It was the first one that Dan had significant responsibility for. It was a different provider group. A different participant group. And we usually have, some discussions built in, like small group discussions or discussion topics that we're asking people to give, not just to ask questions, but what's your take on this? How would you manage this? That kind of thing. And that didn't lend itself to this topic.
Yeah, right.
So I actually think this is good just to get all of our feet wet. I think it also, the other thing I will say is, and there's no judgment going with what I'm about to say, but the prep time was really short for this. And I got the feeling from you, Mary Ellen, that you were not even aware that so many people were going to be presenting. We were sort of expecting one or two from each of the groups, and then to have that many people kind of at the last minute. So things like the sound checks and the tech checks and all that, I think will go smoother in the future, because we'll have people identified much further in advance, and there'll be time to work with them.
That sounds perfect. I know we talked internally about this, and I think too, what we'll do is we'll put together kind of a logistics sheet, kind of a form, so that Dan, you guys can have it ahead of time and let us know as you're making decisions about what specific logistics would be needed. So Lindy, the very first webinar I ever coordinated for SAMHSA, we expected, it was on older adults, substance use among older adults. And we expected maybe 100, 150 to register. And a few weeks before we launched the webinar, there were over 1,500 people registered to attend.
Oh my.
And so I was like so this is no big deal, but it was like tapped in, at the very last minute. Okay, let's switch gears. So it's okay. But we will.
And I think you might find, in the future too, I think one of the things that's helpful when there's more advanced planning than we had for this. The bottom line was we wanted to get this scheduled and done, because it's been in the wings for a long time. But as we're able to plan more systematically going forward, I think one of the things that was helpful in some of the previous ones is that as the logistics folks, you all had a separate contact in advance with anybody who is a presenter to make sure that their equipment works, that they know how to share their screen, you know, all those kinds of logistical pieces.
Yes.
And also, depending on the topic, ask for their presentations in advance, not just so you could put them up, but so that we could take a look at them and make sure that they were really covering everything we wanted covered.
Exactly.
It also allowed for, and once your website is up, that like some of these resources, like these billing guides or whatever, could actually be loaded on the website. So that could be said right there, when people are being said about it, well, we will have, these will be up like by tomorrow, or they're already up or whatever.
Sure.
Which again, couldn't have been done here. I do want to not forget to say though, that it would be helpful if when the website is up, those are the kinds